Good morning, everyone. I'll be presenting on behalf of Obstetric Medicine Unit. So my presentation will be seafood diet issues. So it's a 23-year-old primey, 31 plus 4 weeks gestation, came with complaints of right upper abdominal pain and nausea and vomiting for 1 day. So for the history, she had a sudden acute onset of right upper abdominal pain following consumption of non-vegetarian food, binge eating in a family function. She also gives a history of consuming street side food and binge eating non-vegetarian food for the past 2 weeks because of craving. And also she has vomiting about 7 to 8 episodes, non-bilious, non-projectile, and non-bloodstream vomiting. No history of fever, abdominal pain, no history of fever or loose stools, no breathing difficulty. For the past history, she's a GDM on diet, diagnosed at 12 weeks, hypothyroidism on tablet L-troxin 50 microsody, and also known case of mild anemia. Family history, not a known case. There was no history of any diabetic or hypertension in the family, no cardiac events, no sudden death in the family, no history of any hypertriglyceridemia. So examination, vitals is stable, heart rate of 90, BP of 120 over 80, respirator of 16, and JB was not elevated. Afebrile and tongue and mucus are just dry. Thyroid and breast examination was normal. Cardiovascular respiratory system was normal. Per abdomen, the fetal height was corresponding to the gestational age. She had a mild epigastric tenderness on deep palpation. Otherwise, there was no organomegaly or masses palpable. It's not.
Why uterine rupture?
No, I added, sir. It's not. Okay. So for the differentials, consider a primey with 31 weeks has come with sudden onset abdominal pain with vomiting and with abdominal pain and vomiting. Differentials consider a peptic ulcer disease, cholecystitis, choledocholithiasis, pancreatitis, and TKA. Also, considering her obstetric age, acute fatty liver of pregnancy, HELP, and uterine rupture were considered.
So uterine rupture you will not consider because
she's
hemodynamically
stable. But since
the past history is no fairless years where they put in that midline incision and patient will be very sick.
Hemodynamically stable. Yeah. That's why I consider the last.
Not considering because you are carrying fetal heart rate, your this thing is corresponding. There is no, you're not feeling the baby outside this thing, all that.
So for the investigations, the patient did not have any metabolic acidosis or high anion gap as we see in TK or mesenteric ischemia. Her anion gap was normal. Her pH was 7.4 with a bicarb of 19.8. And other investigations on CBC, she had a leukocytosis with the left shift, but her urine routine was normal. Ketones were negative. And other investigations, her LFT did not show any transaminitis or increased in elevated enzymes like we see in HELP or acute fatty liver of pregnancy. And her bilirubin was in a normal range. But her amylase and amylase and lipase levels were out of proportion, was 733 and 1933. So radiological investigation, since the patient presented with an acute abdomen, we have entered with an ultrasound abdomen where the pancreas was bulky with altered echo texture with minimal peripancreatic fluid, and the MPD was mildly dilated, but there was no evidence of any gallstones, and still CBD was not visualized because it was obscured by bowel gas. So we did an MRCP as there was a bulky pancreas with a dilated MPD. So MRCP there showed an acute interstitial edematous pancreatitis, but the MPD was normal and CBD was normal. So the diagnosis of acute pancreatitis was made, and for the etiological workup, her calcium was normal, phosphorus was normal, her triglyceride serum was 170, not enough to cause acute pancreatitis. Her LDL and HDL levels were normal, her HbA1c was 4.6. So pancreatitis in pregnancy, I'll be talking about the epidemiology, approach, management, and for the epidemiology, the incidence is, so this is from paper in China based on 121 cases. So the maximum incidence was because of the gallstones, and the second one was because of hypertriglyceridemia, and the third one was idiopathic. So the maximum incidence was gallstone, and second one followed by hypertriglyceridemia. Whereas a paper in India says that the first one is gallstones as usual, but the second one is alcohol abuse, followed by third one is hypertriglyceridemia, and the fourth one is idiopathic. So mean age of onset of acute pancreatitis in pregnancy is 28.5 years, and it's most common in third trimester of pregnancy, but there are cases in first and second trimesters also. This is important because mortality in pregnant women with acute pancreatitis is comparable to the rate in the general population, and the trimester in which they present determines the mortality. So the first trimester has the highest rate of mortality, and the third trimester has the least. Least. Whereas if you consider the fetal death, the first trimester has the highest mortality and the second trimester has the second highest. So for the clinical features, if the patient presents with 2 out of these following criteria, acute pancreatitis is suspected, like clinical picture with epigastric vein radiating to the back, pancreatic amylase more than thrice the upper limit of the normal, and features of acute pancreatitis in imaging. And pancreatic amylase is considered because in blood amylase, the level falls in 18 to 72 hours. Within the 72 hours, the levels of amylase starts falling. So patient comes with epigastric pain, possible paralytic ileus, and nausea and vomiting associated with the low-grade fever. So if it is a case of biliary etiology, the patient might also have colicky pains in the right hypochondrium, vomiting and poor tolerance to fatty foods, and even jaundice. So in physical examination, difficult to identify the typical signs like expected in the general population. There will be a tenderness in the epigastrium. There can be absent bowel sounds, and there can be jaundice. So complications, there can be local, regional, or systemic complications. Local complications, like our patient had acute peripancreatic fluid collection. They can form a pancreatic pseudocyst in 4 weeks' time, and they can form an acute necrotic collection and walled-off necrosis. Regional, like a splenic or a portal vein thrombosis, and systemic, like a multi-organ dysfunction, like cardiac or lung complications. So, this paper from China, released in May 2022. So it says that if the patient has a severity, like if it is a severe acute pancreatitis, the neonatal complications are more. Among the 10 patients who had severe acute pancreatitis, the neonatal respiratory distress syndrome 3 babies had. And also, if the patient has hypertriglyceridemia, which is supposed to be the etiology of the acute pancreatitis, the severity is also more. Like it can be a severe acute pancreatitis if it is a hypertriglyceridemia related, whereas gallstone related or idiopathic changes have very less morbidity. Out of the 18 people, 11 people had organ dysfunction when it was a hypertriglyceridemia associated, whereas if it was a gallstone or idiopathic, only 2 or none had organ dysfunction. So like we already said, fetal outcomes, the death is the highest in the first trimester, and second highest in the third trimester, and least in the second trimester. And there can also be a higher risk of preterm delivery, so steroids can be considered for lung maturity of the baby. So the severity stage being used in all these papers is Atlanta severity scoring, although we have Ranson's, Apache, and other scores for that. So these papers state that if the patient has no organ failure or no complications, it's mild. Moderately severe is when there is a transient organ failure or if there is local systemic complication, and severe if it is a persistent organ failure or it's a single or multiple organ dysfunction. So our patient comes into this category of moderately severe acute pancreatitis. So the prognostic factors in acute pancreatitis is if the blood urine nitrogen is more than 33, if it indicates pancreatic necrosis, obesity with a BMI of more than 30, our patient's BMI was 25.7. And plasma glucose greater than 190, SIRS greater than or equal to 2, procal elevation, CRP elevation, and deranged coax, and IL-6 elevated. So the management is hydrate. It's an antispasmodics, analgesics. Antibiotic therapy has no role in prophylactic antibiotics. So like DKA, the counts may be elevated in acute pancreatitis, but it doesn't mean that we have to start antibiotics. Only if the patient has any signs of infection, or if she or he brews something in the blood, or if there is any evidence of any necrosis. Necrosis also can be sterile. If there is a feature of any infective necrosis, then we can start antibiotics. And the modification of risk factors like diabetes, hypertriglyceridemia. If the patient comes in thousands with an acute pancreatitis, insulin infusion should be started, and stopping alcohol consumption. So the fluid of choice for hydration, many papers have controversy. Like some say it's normal saline, some say it's ringer lactate. Ringer lactate is based on the theory that it has a lot of lactates and it can be metabolized in the liver to bicarb, and that decreases acidosis, which is caused by acute pancreatitis. So, and goal-directed intravenous fluid therapy of 5 to 10 ml per kg per hour. So in the first 72 hours, we have to hydrate of 3 to 4 liters, and then assessing the patient to fluid resuscitation based on the targets. So the targets are heart rate of less than 120 with a MAP of 65 to 85 and urine output of more than 0.5 ml per kg per hour. And if the patient is in ICU setting, we can have the clinical targets of stroke volume variation and introthoracic blood volume determination, and the hematocrit. So the patient, because of the persistent vomiting in acute pancreatitis, will have a hemoconcentration. So we'll have to hydrate enough to maintain the hematocrit between 35 to 44. So this is a summary. So when there is a suspicion of acute pancreatitis, the differential diagnosis we can have can be appendicitis or duodenal or gastric ulcer, cholecystitis, choledocholithiasis, mesenteric ischemia, or if the patient is pregnant, fatty liver, preeclampsia health syndrome, placental abruption, or uterine rupture. So if we have confirmed the acute pancreatitis by the clinical and investigation criteria, then it can we have to grade it severe. They grade the severity. So whatever forms, be it mild form or severe form, the treatment is going to be hydration followed by early oral nutrition, early enteral or oral nutrition. And if there is a severe form and if there is a biliary etiology which is suspected, then we have to determine if the patient requires upfront surgery or later surgery. So if there is biliary obstruction with cholestasis, the patient can be taken for ERCP with the sphincterotomy. Without cholestasis, cholecystectomy considered after the pregnancy. So take home points: approach to pancreatitis in pregnancy, fetal and maternal outcomes and management, and see what you eat, don't eat whatever you see. Thank you.
Thank you. Because of the lack of time, we'll move on to the next presentation by Medicine 2, Pranut.
Morning, everyone.